Greetings again, friends. We're going to talk here about Fragile X syndrome. And this is not a tremendously common disorder, certainly not as common as some of the other things that we've addressed previously, like Klinefelter's, Turner's, Down syndrome. But this does come up on the test. It's worth knowing about. So we're going to just do an overview. We'll talk about the genetics, a little bit more complicated here with Fragile X because there's more of a spectrum of how this can present. We'll talk about the features, the dysmorphic features, as well as how these children develop and what their long-term prognosis is going to be and how you can manage this syndrome. So as an overview, Fragile X syndrome is a syndrome that leads to cognitive and intellectual disability, as well as various psychiatric manifestations in some patients. It also leads to a particular facies, craniofacial appearances that are relatively distinct to this particular syndrome. The error is on the X chromosome, and therefore males are going to be affected more often and more severely than females. So if you inherit an errored X chromosome and you're a female, you have another X chromosome to sort of back you up. Now, there are Fragile X syndrome can affect females, and there are some Fragile X related syndromes that can affect females, but by the whole, females are affected less often and less severely than males. About 1 in 2,500 to 4,000 males are affected by Fragile X syndrome, and that's compared to 1 in 7,000 to 8,000 females. The severity of the disease is directly related to the extent of the mutation. Now you might be wondering, what does that mean, extent of the mutation? Here's what that means. So Fragile X syndrome involves the fragile site at XQ27.3, which is a site on the X chromosome that contains the FMR1 gene, and FMR1 just stands for Fragile X Mental Retardation 1. This gene normally contains a set of trinucleotide repeats, and usually there's 5 to 44 CGG repeats. But the problem is, and where Fragile X syndrome comes into play, and how this can happen, is that this trinucleotide repeat sequence can become expanded. And that's similar to some other genetic disorders like Huntington's disorder, where you have an expansion of trinucleotide repeat sequence. And so this is similar in that regard. So if you have an expansion of the CGG trinucleotide repeat sequence, then it's more likely to cause or transmit symptoms. So the number of trinucleotide repeats is going to dictate whether or not there's symptoms or risk of transmission. 5 to 44 CGG sequences repeats is normal for this gene. If it's 45 to 54, that's considered a borderline risk between normal and a premutation. A premutation is 55 to 200 CGG sequences, and premutations are what leads to some of those Fragile X related syndromes where you don't actually have Fragile X syndrome necessarily, but you have some a syndrome that's related to this particular gene, dysfunction of this particular gene. 55 to 200 is the premutation of FMR1, and then anything more than 200 is considered a mutation of FMR1. And like I said, because it's on the X chromosome, females who inherit an X chromosome with a premutated or mutated FMR1, they tend to be less affected than males would be. Males, however, will display the typical symptoms. Genetically, this disorder is therefore considered X-linked dominant with variable penetrance. So here's just a schematic of the FMR1 gene. So this is normal here. You have a CPG island at the end of the gene. You have your FMR1 gene right here. And then in between that is this trinucleotide repeat sequence. Now, if this sequence becomes too long, then various things can happen to this gene where you can get deactivation of the FMR1 gene. And that happens when you have too many trinucleotide repeat sequences. So you get your various genetic processes that go on inside the nucleus hypermethylation, reassociation of acylated histones, RNA inactivation, and so forth. And this leads to the FMR1 silencing, which ultimately is going to lead to Fragile X syndrome. So this is the FMR1 gene, and this would be an example of where you would get the Fragile X syndrome. So just to note here, the premutation you can get these Fragile X related syndromes where you can get Fragile X premature ovarian inactivation. You can also get a gait and dementia disorder, which we'll talk about later on. So what does FMR1 do? FMR1 encodes a protein called FMRP, which just means Fragile X mental retardation protein. And this protein normally serves various roles, particularly in the brain. And it's a deficiency of this protein which causes the cognitive deficits or mental retardation. This protein allows for synaptic plasticity, which is the way that the brain develops and changes and moves its synapses, and therefore there is difficulty with Fragile X syndrome in terms of memory. FMRP also plays a role in the regulation of glutamate receptors on neurons, and a lack of FMRP has been associated with more glutamate signaling. And remember, glutamate is an excitable neurotransmitter, and so this excitability can be behind why we see some of the CNS symptoms in Fragile X syndrome, and that includes anxiety and epilepsy. Okay, that's just for your information here. So the FMRP is responsible for reducing the amount of this AMPA receptor, and this AMPA receptor allows for transmission from glutamate. So this is sort of the getting into the nitty-gritty of it. So what are these features that we see? Okay, well, looking at the cognitive and behavioral aspects, because this is where all patients are going to have these things. There's always going to be a developmental delay, borderlining on mental retardation. Usually it is in the mental retardation range. The average IQ is 40, so that's quite disturbed. Autism can be seen, or autism-like features, 20 to 30% of patients. ADHD is seen in about 80% of patients. You can also see symptoms that are consistent with obsessive-compulsive disorder. And then almost all patients are going to have anxiety, particularly social anxiety. You can also see, and you tend to see in males, when they're affected with this, they'll have macroorchidism, and you won't always pick this up when it's a child. Only about 40% will have macroorchidism before puberty, but 90% of patients, once they hit puberty, will show signs of macroorchidism. Macroorchidism is just enlargement of the testes. The craniofacial symptoms or features are what really defines this in your stereotypic cases, but it only actually happens in 60% of patients. So the features that we see on the face are these large protruding ears that protrude outwardly, and a very elongated face and forehead, and then a high arched palate in the mouth. You can also see disorders of connective tissue. These patients tend to have joint laxity. They can have mitral valve prolapse. They tend to have flat feet, and they can also be at risk for scoliosis. And then neurologically, they have a risk for seizures, probably due to the glutamate issues, recurrent otitis media, strabismus, and hypotonia. So this is a cartoon of what Fragile X syndrome looks like in your stereotypic case. Note here the very elongated face, large forehead, and the prominent sort of outturned ears. Here's another cartoon here. So just showing a broad forehead, elongated face, large prominent ears. They can be cross-eyed, highly arched palate. And then their joints are hyperextensible. They can have hand calluses from self-abuse. That's typically relates to those sort of OCD-like symptoms. Then pectus excavatum, that's that indentation into the chest. Mitral valve prolapse, enlarged testicles, that's just macroorchidism, and then flat feet and seizures in about 10 to 20%. So this is an example of the Fragile X facies in a child. Note the outturned ears, very pointed chin, broad forehead, and it'll become more prominent as he gets older. So here you note in adults, at least these two on the side and this one on the right here are adults. You can see these very characteristic features. Developmentally, during childhood, their physical development, their gross motor milestones may be delayed because of hypotonia. And if you already have a diagnosis on these children, you can send them to physical therapy to help with that. Fine motor milestones can be delayed as well, and macroorchidism can be noted during childhood in about 40% of patients. Cognitively, there's going to be significant delays because of the mental retardation. You can also see some of these features that are similar to what we see in autism, like echolalia and self-talking. That may manifest later in childhood, whereas in autism, you kind of see the symptoms earlier on in childhood. So there's autism-like features, even though it might not necessarily be flat-out autism or technical diagnosis. The IQ ranges from 20 to 70, and it's negatively correlated with the number of trinucleotide repeats. So the more trinucleotide repeats there are, the lower the patient's IQ is going to be. And then social development, particularly noted with that social anxiety, which is seen almost universally in children and adults with Fragile X syndrome. During adolescence, because of the significant cognitive deficits, life is often significantly affected for these patients. They can also, at this point, start to develop other psychiatric disorders, including, more notably, OCD-like symptoms. Typically, these patients have shorter than expected stature. They also have a propensity towards obesity. For diagnosis, you get molecular analysis. And you're looking for that trinucleotide repeat sequence. You can quantify that, and by quantifying that, you can determine the severity based on a genetic analysis. To diagnose Fragile X syndrome, you want to do this molecular analysis, but you can do this at various points. So when are you going to get a molecular analysis for Fragile X syndrome? Well, one, you're going to get it to diagnose Fragile X syndrome, obviously. You can do this prenatally if there's a family history of Fragile X syndrome. So if there's a history, for instance, mom has some brothers, some male cousins, uncles who have a history of this abnormal-looking face, maybe a little bit slow, maybe dependent. That's certainly a possible Fragile X gene in the family. Then in that case, she may want to have her child, especially if we already know it's going to be a boy, to have that diagnosed prenatally. And that can be done via the amniotic fluid. Postnatally, you're just going to get a blood test. You can also get a molecular analysis for Fragile X syndrome to diagnose Fragile X-related disorders. We'll talk about some of those in a little bit. But those include premature ovarian failure, early menopause, Fragile X tremor, and ataxia syndrome. And then you can also use this molecular analysis to determine carrier status as well. And that's something that if you're parents and you have a son who's got Fragile X syndrome and you have a daughter who's normal, you may want to have her checked to see if she carries the Fragile X gene, because then in that case, she has a risk of having children with Fragile X syndrome. Once you've diagnosed the syndrome, the patient should be screened for heart defects. Remember, mitral valve prolapse is the most common. There are no cures for Fragile X syndrome, so the management is going to be based primarily on symptoms. So cognitive deficits are really the most severe as far as impacting the patient's quality of life. Occupational therapy to maximize their function is useful as appropriate to age, speech therapy, and special education support. If they have seizure disorder, valproate, carbamazepine can be used. There's probably other anti-epileptic drugs that can be used as well. ADHD is pretty prevalent in this population, so in that case you can use stimulants like methylphenidate. just like we would for anybody else. For anxiety, you can use SSRIs, behavioral therapy, pretty much just like in everybody else. And because they may have these aggressive outbursts, you can use atypical antipsychotics. From what I've read in the literature, aripiprazole and risperidone are the most effective. And like I mentioned previously, parents should see a genetic counselor and family members should be informed and screened. So long-term consideration, parents should seek counseling to assist with matters of discipline and behavior modification techniques. To foster independent living, adults should be placed in the least restrictive environment that is safely acceptable. Work training and special education programs can be utilized, and they can be found in communities that maximize function and independence. There are some foundations for Fragile X syndrome, or patients, parents, and patients can get information regarding their syndrome, support groups, and whatnot. Social worker can be really useful for some adult patients if they have no support structure, because a lot of these adult patients are going to be on the lower side of the IQ range, and so a caseworker can be useful to help them apply for benefits, welfare, and unemployment, and anything they may need as far as medical insurance. The life expectancy with Fragile X syndrome is normal despite all of these ramifications. Okay, now these Fragile X related disorders are due to premutations of the FMR1 gene, which, remember, the premutations are if you have 55 to 200 expansions of the trinucleotide repeat sequence. So this is going to lead to various disorders. It really just depends, but it can lead to premature ovarian failure and early menopause. Now, really the only difference here is the age. So premature ovarian failure is going to be a cessation of menses for more than 6 months in a woman younger than 40 years. And then early menopause is going to be the same thing in a woman aged 40 to 45. After age 45, it's considered normal, quote unquote, to get menopause. So early menopause is in a woman 40 to 45. Premature ovarian failure is in a woman younger than age 40. But really, the only thing that's separating the definitions of these two is just the age of the woman. Both of these can be managed with hormone replacement therapy if the woman wants. Otherwise, you don't have to. If she wants to become pregnant, or if there's some reason why she wants to continue having her period, and when you do hit menopause, there are issues with vaginal dryness and stuff like that, hot flashes, then certainly you can go ahead and supply her with hormonal replacement therapy for as long as she needs to, or up until the point where she would normally hit menopause. It's really up to the patient with their informed consent. Fragile X tremor ataxia syndrome is something that more commonly happens in males. This is a Parkinsonian-like syndrome. It also involves dementia and cognitive decline. Typically, this sets in around 50 years of age or older. And so you really see, it sort of pretty much looks like a Parkinson's dementia. And so you get a tremor. The tremor can be managed with beta blockers, such as propranolol. They may have Parkinsonian-like symptoms. That can be managed just as you would Parkinson's with carbidopa-levodopa. Cognitive decline, you manage this just like you would Alzheimer's with acetylcholinesterase inhibitors. Anxiety or depressive symptoms can be managed just like we would for Fragile X syndrome with venlafaxine or SSRIs. They can have a neuropathy as well, which can be painful. For that, you can give them gabapentin like we would for diabetic neuropathy, for instance. So you're just managing this symptomatically. And then finally, there's something just called neurodevelopmental disorder. I probably shouldn't have boldfaced that because that's not technically the name for it. But it's just a neurodevelopmental disorder because of a Fragile X premutation. So it's a premutation, and this is just going to cause really mild Fragile X features and manifestations because you don't quite have, you don't technically have enough trinucleotide repeat sequences to be considered Fragile X syndrome. So you're in that 55 to 200 range. But you can still see some Fragile X features in these patients. But ultimately, you're just going to manage them the same way, manage their symptoms the same way as you would for Fragile X syndrome. But I just wanted to highlight here that you can have Fragile X features even if you're less than 200 sequences. It's not like 200 is just some magic number. It's just sort of the number that we came up with, whereas at 200 or more, you really start to see very severe symptoms, whereas below 200, you can see symptoms, but they're much less severe as the trinucleotide repeat sequence goes down. So if you have any questions, feel free to write a comment below. I will see you next time.